I'm just going to take you through quickly the Dorset system. We are very similar to Hampshire and Isle of Wight, slightly smaller population of about 840,000, an operating budget of about 1.7 billion. But I'm going to say one thing, and you never hear this, and I'll tell you why later on, is dental practices that we have in Dorset, number 90. How many other ICBs tell you how many dental practices they've got? They tell you how many GP practices. Why? Because I'm the oral health director for Dorset. So, Dorset system. This is our sort of plan on a page. We have the 10-year plan that created the ICB strategy. Like Hampshire and Isle of Wight, we cracked this about 22-23. We focus on added life healthy years. That's what the strapline, the mission is for Dorset. We have an health equalities plan. We have 4 pillars. They're referred to as 5, but actually healthy lifespan is actually an all-encompassing pillar. And then we have improved the lives of 100,000 people impacted by poor mental health. 55 children reduced from to stop being overweight by 2040, reduced the gap in healthy life expectancy from 19 to 15 years by 2043, increased the percentage of older people living well and independently, and also adding 100,000 healthy life years to the population of Dorset by 2033. Underpinned by a number of plans. So Dorset Healthcare, NHS talked about their clinical strategy. We've got the Integrated Neighbourhood Plan, which is one of our major priorities. Estates, Research and Innovation Plan, which we have. It's actually research, but we're going to add innovation this year. Clinical strategy, digital strategy, and a transformation roadmap. The key thing is, research and innovation appears in all of the strategies. We have to influence. How many in our team in Dorset, just for research and innovation? 2. Sarah is my second in command over there, does research and innovation. And we've got Heather and Andy in the room from Dorset Intelligence Insight Service. I had to give them a bit of a, I was told if you don't mention us, we're not buying you coffee this afternoon. But that is really important because we use intelligence and insight to drive the decisions that we make. So we were talking about earlier about the data. Don't make decisions, they need to be evidence-based. Why are we doing this? Really important about how then you take a strategy and make it work. So here's an organogram. Lots of stuff going on. Only focus on the one with the red line around it. That's the clinical professional reference group. It's the body where the clinicians all come together as a team to look at research and innovation in the wider context of other clinical priorities. It's where decisions are made, and it pushes into the system executive group, which is the body where the execs then reinforce the decision and make it happen. They give us the permission. And then that goes into the ICB board. The other thing is, we've talked about ICBs, but once again, we must talk about integrated care partnerships. We must talk about integrated care systems. We're a team of teams, to quote the Crystal. We are partners, we work together. It's not just about an ICB, it's bigger than that. And in the way that we've run our research, we have a partnership approach. So we've got our partners there, our hospitals, both acute and primary. We've got our primary care, we've got oral health, we've got, including dentistry, we also have optometry, we also look at pharmacy. We look at local authorities, our 2 partners who are key with us, and the third sector. I could talk about the police, the fire service, I could talk about the RNLI. All of those people are part of our research. They all have a part to play. And the idea is we also have groups within Dorset, like the Dorset Clinical Trials Unit. These people are all part of the partnership work. I don't like these things. I like networks. I don't like organograms. These look very structured. It's not how it works. It works on networks. Samira Gray has been mentoring us as a team for the last 2 years, and we talk about moving from hierarchical systems to networks. The clinical network in Dorset is the most powerful network. And below that, you have an aging well network, a children and young people healthy weight network, where both clinicians, managers, financiers, third sector come together, and that's where the business is done. That's how you do business in a ICB. Look, this is the fun stuff, right? I'm hopefully going to give you some time back. So I'm just going to talk about one thing. So Julie's in the room. I will mention loads of people. I will embarrass them. Julie's from the Health Services University, a partner. We have created an oral health institute. We contracted it. And when we contracted the Oral Health Institute, we put in research as a key performance indicator. They have to deliver to us research in oral health in order to meet the contract. So we're formalising how we can do research. Why is that important? Because the money starts to flow. It allows me to go to the region and get money. It gets me £2.5 million that was going to go to the Treasury back into the system to support these projects. That's a lot of money and resources that can deliver effect on the ground. And the first one we're going to do is we've commissioned and contract research for homeless and domestic violence. So what we've got Dental Aid. If you've never heard of them, they're a mobile dental system that goes around the country. They've got contracts with ICBs, and they deliver mobile dentistry to those most in crisis. We're talking about homeless, asylum seekers, and victims of domestic violence who have to leave their dental practice to escape the persecution they're under. They're in ultimate crisis. How do we deliver that? They set up a system. They work with 3 of our charities, so the Bournemouth Churches, the Lantern Trust and Health Bus, and they manage the clients so that when they arrive, the bus arrives, they arrive, they get together, they bring in other agencies, and we deliver dental care to people in crisis. Stories of people who basically have no pride because they have no teeth, and we give them dentures, so we give them support, and we do that through the system. But what's the impact? How powerful is that? What is the access issues? So we are going to commission. Now, I don't know what the research question is, Julie, yet. Do you know the question yet? What you're going to do? You don't know yet. No, but she's working on it. But the idea is that we want to understand what that research question is, and we're going to fund that as part of the commission service. So we're going to do the research and the delivery to understand how we then move forward. And then do we commission in the future, we commission the right thing based on clinical evidence, based on what we're seeing on the ground. That's the way that we do it. We listen to the people, and DICE are producing a dashboard to provide the evidence so that we pull this together to give us the insight to make sure that we can look at performance, look at the different, they've got the ability to lay over deprivation, to lay over different areas, different groups. This is really important, bringing all these people together. I have a team of 2, but I borrow loads of people to make things happen. That's it. If you want to meet the team, please link up with Sarah later on in time to talk about the Living Lab. The Living Lab is, I see Dorset as the lab. Everybody is part of research, the whole community. If you want to know about DICE, the team's over there. If you want to know about the HSU and their amazing work on oral health and what's going to happen, please pin Julie. I think Mel's in the room as well, and also we've got Helena. The reason why, we built this research on the research that they've done through working with the homeless community. So we've learnt from what they've done and we've created something else, and you'll hear about that later as well. So thank you for your time. I'll hopefully give you a couple of minutes back. Thank you.